And at the moment, we have 14 people signed in from various places. If you don't mind entering in your name and your role, your organization, location, and even if you have any particular interests in this topic, collaborative care, sustainability, and also if you have any other particular topics or speakers that you would like to hear, feel free to chime in. This group is becoming a, I guess, bottom-up interest of people who are psychiatrists and other types of prescribing. We've had some psychologists, nurse practitioners, and PAs, but also people that are not psychiatrists who are interested in psychiatry and in behavioral health integration and needing to learn more. So we want this to be a group that can have foster lots of conversation and learning and sharing. And we've had some good meetings in the past. And if you haven't had a chance to look at our website, we are posting the recordings and some links. And so please let us know what you're learning and what you would like to learn, and how we can make this a good group and a good program. Feel free to put in questions in the chat as we go. But I think it'd be good, Virna, if you want to go ahead and
Sure.
Introduce yourself, and I appreciate the way that you have helped me in terms of understanding the collaborative care model and some of the in the weeds, how to make it work in terms of documentation, coding, billing. So you have a wealth of knowledge and experience. So welcome and appreciate you.
Well, thank you. I'm super glad to be here. Since we're a smaller group today, and since Zoom is being very presumptuous in that it doesn't think I can watch the chat and present at the same time, even though I am quite confident I can do that. So why don't we just, if you have any questions or comments, literally just, unmute yourself and jump in. I will not be offended and would actually prefer the discussion. So my name is Virna. I'm currently the Chief Operating Officer and co-founder of a company called Concert Health, and we provide collaborative care services to primary care organizations around the country. We're in 8 states currently and growing. So I've been doing collaborative care for quite some period of time and have had lots of opportunity in both organizations that I've worked in and run and organizations that I've helped to sort of get collaborative care off the ground, to be able to be in the weeds. So that's my favorite place to go, and I think it's often the most helpful. So I really just want to level set. I have learned actually fairly painfully to always level set, because inevitably as I'm interviewing people and talking to people, they say, well, yeah, I really like to collaborate. And so have to just always level set that we are literally talking about the evidence-based model collaborative care to identify and treat patients with depression or anxiety in primary care settings by adding 2 people to the primary care team, the behavioral health care manager, and then many of you functioning as the psychiatric consultant. So again, just doing some level setting. I did actually put up here the billing and the code so that people can also level set that we are talking about the monthly case rates that are tied to collaborative care. These are for the non-FQHCs or rural health centers. And of course, now there is another G code that they have added for 30 minutes, which we'll talk about a little bit later. So they actually did add a code here. So essentially, if you're doing this work, you have 5 codes to choose from, unless you live in New York, and then you have 6. There is 1 code that is actually only recognized by New York State. But essentially, what makes this different is the monthly case rates and the tracking of the minutes, which is a lot of times where people tend to get a little caught up. And I did mention not in Medicare or not in rural health centers or FQHCs. I think the thing about the FQHCs is that they cannot do the chronic care management, whereas other organizations can do the chronic care management and collaborative care, whereas the FQHCs and the rural health centers only have those 2 G codes to choose from, and that's it for Medicare. And so I think a lot of times the FQHCs and the rural health centers get confused because they kind of threw those G codes into the mix. They made them the same as the chronic care management codes, essentially to send the message that they didn't want them both to happen at once. But I think then sort of created a bit of confusion for people. So when we think about the collaborative care codes being on the Medicaid fee schedule, there are 18 states now. There are several that it's pending. It certainly does make implementation and adoption much easier in a state where it is in the Medicaid fee schedule. When we think about what the rates are kind of all over the map, to be honest with you. New Hampshire and Pennsylvania are the lowest. You know, they're in like the $70 range as opposed to maybe the $150 range in some of the other places for some of the 99492 and 493 codes. So that certainly does make things a little bit harder. California was the latest, actually. They just passed the codes in January and just recently have sort of been working out what the fee structure is going to look like. They actually timed it, for many of you familiar with the California landscape, with some of the behavioral health integration grants that they gave out there. So certainly now trying to sort it out across the payers, but they are actually officially on the Medicaid fee schedule. Probably the most organized one is New York. They have the Collaborative Care Medicaid program. They like to New Yorkify things, and so they actually put in place an application process. You have to be accepted in order to bill Medicaid. You have to show that you have certain components in place. You have to then have your rates loaded and they get submitted directly to Medicaid. They carved out all of the Medicaid managed care plans and it goes directly to Medicaid. They've offered technical assistance. So I think that has really been helpful in terms of adoption in New York. There's been other statewide efforts like Montana Health Foundation paid for learning communities and some other activities. Certainly in California, there's going to be support and training around some of the integration grants. So there is some things going on. When we think about billing Medicare and the commercial plans for collaborative care, most Medicare Advantage plans really need to pay these codes because they are connected to Medicare. We have not really had an issue with Medicare Advantage plans nationally. There's only one plan in New York that is not paying. I actually think it's a glitch. I have reported it to them and hopefully they're gonna get on board. One of the things that you are seeing is that they are limiting to 2 99494 codes. So 2 of those 30-minute add-on codes. Medicare will deny those claims. There is theoretically an appeal process, but nobody's actually really figured out how to do that successfully. Many of the commercial plans will not pay more than the 2 99494 codes. There are some like Aetna and a few other, union plans and some others that do. There are also a few that don't pay any at all. So one of my suggestions to you is that as you start to do this for your commercial plans, if you can find guidance for what they pay, then absolutely do that. We have a library of some guidance, so I'll give you my email at the end. You're welcome to email me. The guidance is, of course, frequently changing because what fun would it be if they left it all the same? But there are literally some plans that have no guidance, but have sort of made some decisions. And so what I usually do is tell people, if you can't find the guidance, then, really try to play with the claims. There are many times when the commercial plans will actually deny a claim if it has more than 2 494s on it. They won't just deny the multiple 494s. The third 494 is an example. They're literally deny the whole claim. And so oftentimes that creates some confusion. So I really encourage you, you're going to have to think. What I tell organizations is start with the 2494s and then kind of work from there, because that's a good baseline to start. A lot of times the FQHCs and the rural health centers get confused because they've got the G codes for Medicare and then the CPT codes for their commercial and Medicaid plans. So it makes life a little bit more complicated. Of course, your Medicare rates are going to vary by region, like Medicare rates tend to do. And these certainly do vary. There's certainly big differences from what is reimbursed in, in New York City, or as opposed to what's paid maybe in some of the other counties across the state. And the commercial plans, when we really think about how they should be paying in terms of maybe a percentage of Medicare, the commercial rates are all over the map. And they will literally have $100 range, from a $30 reimbursement to $130 reimbursement. The range is pretty incredible. And I think it's a broader range than I've really seen in other places for other codes. And there are some commercial plans that pay really, really nice. And there are some commercial plans that, should be publicly shamed. And I will actually do that a little bit later on. But so in other words, when you're really thinking about a business model, it's really important to think about what percentage you have of your commercial plans, and then really do some digging around the reimbursement. So when we think about staffing, I still get a ton of questions about staffing. And there's a couple of things that I think are important to know. One is sort of legitimately what you need to know about staffing, and two, what's sort of helpful or a best practice. So certainly, because these are monthly case rates and they are billed under the primary care provider, or the specialty provider, or the women's health provider, and we'll talk a little bit more about that, then it gives you the ability to hire some additional kinds of clinicians. So for an example, a licensed mental health counselor is not recognized by Medicare, couldn't bill Medicare directly, but can be a part of a collaborative care team, which bills Medicare, because it is under the primary care provider and they're an acceptable type of provider here. So a lot of times people will get confused around credentialing. So you wouldn't need to credential those providers. You wouldn't need to list them for the plans. In fact, CMS says that they don't need to be licensed. So certainly I think that in order to provide the spectrum of services under collaborative care, it's helpful if somebody is master's prepared, if not licensed. Certainly I think that makes it a little bit easier for them to really do the work. But there still tends to be a lot of confusion about what it looks like. It is going to change, and we'll talk about this more. If you are going to bill for individual visits and collaborative care, then you need to think about your staffing a little bit differently, because then a lot of those things that I just said don't matter, do matter. Although it is not necessary to bill the independent visits to make collaborative care self-sustaining in most cases. So a lot of times what I do is tell organizations, don't even worry about the independent billing first. Get collaborative care down, start doing that, get it figured out, make it self-sustaining, and then make some decisions about when and where you might bill for individual visits. And that's a really helpful way to do it, just to help people get collaborative care under their belt, but it gives a good foundation for that behavioral health collaborative care manager, so that they don't get confused. One of the things that I think I hear a lot is sort of wanting to plug existing staff into covering gaps. So I got a call yesterday from a primary care provider who had an LPN, and she was doing like some care coordination things and some follow-ups. And he's like, tell me how I can use the collaborative care codes. And so really thinking through what that looks like, and really making sure that they're going to be meeting the requirements of collaborative care. One of the things we know does not work, I would say more than 90% of the time, is to have an existing behavioral health provider who is in a primary care practice and then have them add collaborative care to what they're doing. That doesn't work. It doesn't work for lots of different reasons. It doesn't make for a robust collaborative care program. It does not work for making a happy behavioral health care manager. Just lots of different reasons, and glad to talk about why. What you often find is a very low collaborative care census for lots of different reasons, but certainly a lot of times, I will say to people, we're not even gonna work on that implementation unless you can try to figure something else out. So probably the most complicated piece is really billing the individual visits as part of collaborative care. And so talk treatment or individual therapy counseling visits are part of one of the treatment choices of collaborative care. So I always know, if I ask someone, how many people do you have enrolled in collaborative care? And they tell me 40. And I say, well, how many people are in talk treatment? And if they tell me 40, then I know they're not doing collaborative care, right? That they're just doing traditional mental health services, and somewhere somebody along the line decided to call it collaborative care. But really, it's about letting people know the treatment choices. And some people do choose to have talk treatment or counseling or therapy every week or every other week. And so there is the ability to bill those individual visits in addition to collaborative care. And a lot of times organizations are under the impression that if they don't bill those individual visits, because that's what they're so used to, that collaborative care will not be sustainable. And in most cases, that is actually not true. However, if you're going to bill for these individual services, then you do have to make sure that that provider is credentialed. You do have to make sure that the psychotherapy codes are in your contracts. You do have to document them separately. And you do have to know that those minutes that you're billing do not count towards the collaborative care minutes. So any time that I spend in therapy that's getting billed out does not count towards those monthly minutes. And a lot of times that's where people get confused. And so also then this affects your staffing, because if you have a lot of Medicare patients, then you might not hire an LMHC to do collaborative care if you're really planning on billing these individual visits, because they wouldn't, be able to do that. So one of the most important things when you're thinking about setting this up and you're thinking about billing both is that to actually bill both, you need to do both. And this is often where I see the biggest problem. So I will see a couple of different things. One is I'll see a social worker or a behavioral health care manager, and they're seeing someone for therapy, and then they'll call them once or twice a month to do the PHQ, and they'll have psychiatric consultation. But if I look at what's happening in the therapy sessions, it has nothing to do with collaborative care. There's no mention of the PHQ or GAD. There isn't really a shared plan that goes across what's happening on the phone calls and the psychiatric consultation to what's happening in the talk treatment. And talk treatment is a choice as a part of collaborative care. So it should be consistent. I should, start that session off with the PHQ or GAD. I should have the same goals and the same care plan, right? I should be carrying those goals from talk treatment into maybe a follow-up phone call. I will often see sometimes that organizations will say, I'm working with an organization now and they have community health workers and they have licensed clinical social workers. And so they had the community health workers calling patients, giving them the PHQs, and then they had the LCSWs doing therapy, and the two had no cross. So they were billing both each month, but they were not communicating with each other. They were doing completely different things. They weren't referencing what the other one was doing in the notes. And so that's often a really hard model to follow. But you really do need to do both. So I think it's important to have the same person do both. It's very hard to split it. What we ended up doing there was that if a patient chose to get symptom monitoring, to get brief check-ins to get medication adherence, they would actually be followed by the CHW. And if they chose talk treatment, they would be followed by the clinical social worker. And if they chose talk treatment and other models, they would get followed by both so that they could start to really work together and to develop some pathways in terms of billing those individual visits. If you're going to bill the individual visits, then if it's taking you time to get someone credentialed, as an example, with a plan, then you can count the minutes towards your collaborative care episode because you're not billing them out. So I know oftentimes people will get a little stuck on what some of those will look like.
Hey,
So
Virna,
yes.
we have a question that this might be a good point. What data do you utilize to advocate for one person to do CoCM versus adding CoCM onto a PCBH clinician?
Yeah, so first of all, what I like to do is take the payer mix and then look at the rates down the payer mix. And also, and we're going to talk about this more, to look at what the numbers are. One of the biggest failings of implementations in collaborative care is not getting enough patients to really make it sustainable. And so then really figuring out at what point someone is sustainable, which is generally between 50 or 60 patients, sort of depending on your payer mix. But generally, I really like to get people sustainable by the second month. Thank you. Those are fun questions. So if we think about what some of the considerations are, certainly you want to take rates adjusted by region. So for that organization, if you have a large organization that covers a large region, then your rates might vary. Also, your rates are going to be adjusted for nurse practitioners, as an example, particularly for Medicare or maybe for some other payers. These rates are adjusted yearly, so the rates did just change. Medicare actually just changed them recently for 2021. With the exception of federally qualified health centers, patients can be enrolled in chronic care management and collaborative care at the same time. So certainly to remember that those two programs do work hand in hand. A lot of times people will ask me about specialty providers. I'm working in several projects right now in OB/GYN and women's health centers. Collaborative care is a wonderful match for those practices. And I say that because a lot of women of childbearing age don't actually go to the primary care provider, right? Their GYN provider is kind of the provider that they tend to see more. But also, you know, we could fill every one of our offices with the research around the importance of identifying and treating depression and anxiety in prenatal and postpartum populations. So certainly super important. Where you do run into some bumps with, you know, OB/GYN providers and some of the others is that there is some, you know, thoughts about their comfort level to prescribe some of the medications and to carry patients. But certainly in some of the specialties like OB/GYN and cardiology, where they do actually see people and tend to follow people longer. Like if you talk to many seniors, they have a cardiologist. Like I know my grandmother never saw her primary care provider. I don't even think she really knew who she was. If you asked her who her doctor was, it was her cardiologist, right? And so a lot of times, many of them will prescribe meds and are great matches for, you know, collaborative care. A couple of things to remember is that we have come across some payers that will not pay for specialty. So as an example, we partnered with a pain doctor and they would not reimburse the collaborative care codes. So I would really encourage you. One of our biggest fans is a podiatrist in Arizona. He sends us lots of patients in the family practice center he works at. And it's always a problem when they don't also see the primary care provider there because they won't reimburse the claims for him. The other thing to keep in mind is that there are higher copays. So whatever the specialty copay is, so if my plan says that my copay is $75 to see a specialist and $20 to see a primary care provider, then these are going to be a $75 copay. So we are seeing the specialty copays get carried over into collaborative care. I really encourage you to think about some of the special populations, like medication assisted treatment as an example. I generally find that there's a huge crosswalk between patients who will really do well in collaborative care and medication assisted treatment. It's really flexible for them. They can, make different choices and they do super well. And we have lots of centers that we work with around collaborative care and MET. Also, their HIV populations. I know I ran HIV programs for years, and I always was so restricted to whatever my grants were, that oftentimes we were like, we're not actually doing what patients need. We're sort of always limited to what these grants are. And collaborative care really gives you the opportunity to provide some of those behavioral health services in a very patient-centered way and maybe generate some revenue to not be so grant specific. Also to really make sure that you have a referral in the chart and recognition of the diagnosis by the provider. So a lot of times you want to make sure that the provider does document the referral. I will actually have in my workflows for people to double check to make sure it's there. If there was a warm handoff so that they can make sure to go back and put that referral in.
Hey, Virna, we have a couple more questions.
Oh, great. Bring them on.
Yep. So I've asked a couple people to speak up, but one of the questions is, any tips for engaging the PCPs to drive up the referral rates?
Yeah, we're going to talk about that. Okay. Hold that question. Yeah, that is the big problem.
In systems that have an existing integrated behavioral health program or person, how do you recommend building in concurrent CoCM program that's not asking the BHCs to take on another role? Maybe Diana can speak up if I didn't get everything. Does that make sense?
Yeah, what I would say, and also working with a lot of organizations with embedded, behavioral health, is what you really want to try to do, especially in your FQHCs now where you have that UDS measure around depression outcomes, right? But you want to manage your entire population of patients with depression and anxiety. So in a primary care setting, there's lots of people that fall outside of that bucket that are going to benefit from other behavioral health evidence-based practices, right? The other piece is that, so as an example, we worked with a practice in Arizona. They had 8 providers and they had 50-ish patients at a time engaged in behavioral health services. And then we really talked to them about their entire population and what it looked like. And they ran a report and they had over 1,000 patients they had started on meds or refilled meds, in the recent months that were not known to behavioral health, had not had a behavioral health touch, and nobody really knew how those patients were doing. Are they getting better? Are they taking the meds? There's no care plan. We're not measuring how much better they're getting. And so that's your collaborative care population to say, okay, of our total population, right? Here's all of the ways that we can touch everyone with all these different levels of touches and evidence-based practices that might be helpful for them. And there's hundreds and thousands of patients in a lot of systems that are never going to get touched by embedded behavioral health for lots of different reasons, but this allows you to really give them behavioral health touches that are appropriate and helpful for them. And that's really how to sort of work with embedded behavioral health. And really, it should be a flow between the two, so that collaborative care is sending people to embedded behavioral health because they want to continue treatment, or maybe they have some different needs or different diagnosis. And then people in the embedded behavioral health are sending people to collaborative care. And so it should be a real back and forth in terms of covering an entire spectrum of services. It's not an either or.
Monica, did you want to speak up about your question, or did that get that?
Yeah, that actually answered half of it, what Diana asked. I completely agree that it's not an either or. As a clinician that has had to do both simultaneously, it is not fun. It is, you make it happen and you make it work, but it is not fun. I think my question was more around in those situations where the BHC does not have the option to flow back and forth with another person who might be the care coordinator, that the BHC is being asked to wear that hat as the person who's going to do PCBH and wear that hat as the care coordinator. Mm-hmm. Time is what always ends up coming up as being the challenge and the problem, especially if you want to really do, knock it out the park with the model. I feel like you really have to have the time to do the value-based side of things. And so just any guidance on how to get those who hold the decision-making power to understand the benefits of not piling that onto your BHC clinician, but either investing in a care coordinator, whether it's, a MSW, BSW, whatever individuals decide, but investing in that versus adding that on to an additional responsibility of a clinician.
Yeah, it never actually works well, and it never really is sustaining. In fact, they wind up, oftentimes losing as a result. And there's a couple of things too. A lot of times people don't understand, and so they don't change. Like, I have so many behavioral health providers call me and they say, I don't know what to do because they added, collaborative care onto me, but they never changed my productivity, or they never changed my schedule, or they never changed how I document. And so that's just got disaster written all over it, because that's become sort of not a doable situation. And so, the way to really think about it is you actually have to be really thoughtful about what percentage of my patients are going to be collaborative care? How am I going to have two different sets of requirements? What is that going to look like? And you have to sort of thoughtfully plan it. And what I would say is, if you get patients with depression and anxiety, go through the treatment choices, and then if they choose talk treatment, then, you schedule them. Otherwise, maybe you have blocks of time that you use to do some of your other follow-ups. But you really have to think it through based on your population and how many patients. And, it can't just be now you're doing this, but we're not changing anything else.
Gotcha. Thank you.
Yeah. And if you ever want to, if there's ever anybody that wants to get on a call with their administration, I'm glad to give up 30 minutes of my time to save another behavioral health provider.
Don't you say that, Virna. Don't you say that.
I wouldn't say it if I didn't mean it, my dear Monica. And so absolutely. Yeah, because it's not tenable. And a lot of times I've talked to so many senior managers and I've heard them go, oh, there's a light bulb, like, oh, no wonder this isn't working, right? Because we never change the documentation. We never change the schedule. We never, and so, yeah, absolutely. That really makes it incredibly difficult.
Virna, you may cover this in a minute, but what is your average length of stay for patients in the collaborative care model?
About 6 to 8 months. And I never use the words brief treatment. Nationally, it just seems to be like 6 to 8 months. For some reason, when you say brief treatment, people, including primary care providers, patients, behavioral health providers, think they're not getting real treatment. And so I say that because that's how long it takes to get someone better. And so that's really how I frame it. So when we think about time-based inclusions, right, what can we include in the time for the month? Time with psychiatric consultants. So if I'm a care manager and I meet with Patty and we talk for 10 minutes, only 10 minutes counts, not 10 minutes for Patty and 10 minutes for me. So only 10 minutes counts, right? We want to make sure we put the actual time. So if we meet an hour and we talk about 6 patients, we can't average it across the board to 10 minutes, right? We want to make sure we're doing actual time. Any discussions or case reviews that I have with primary care, they can certainly document and add it to an E&M code, but we count it towards the collaborative care time. Anytime in my registry that I'm updating my registry, which is required, anytime I'm doing telephonic work with the patient, right? Discussions with collaterals. I taught a wife the other day how to do the PHQ and talk to her about it, right? In-person visits, right? If you're not billing them, then they count towards the time. And you have to make sure that you're documenting. So I talked to a practice the other day and she's like, oh, I talk to the primary care providers all the time. But if you're not documenting it, then you can't count it in the minutes. So you want to make sure you're doing that. Here's one that often comes up. Concrete services are carved out. So is documentation in the electronic health record. So I'm helping somebody with food stamps, with housing, with transportation, with all of those things. Those are not countable towards the minutes. And all of us could argue that that certainly is important. All of us could argue that it impacts the mood of our patients and the well-being of our patients, but you would be arguing to the wrong people. So the case management and those services are carved out. Registry updating carved in, documented in the electronic health record carved out. What I do is when I'm on the phone, I'm documenting in the electronic health record. And then when I hang up the phone with the patient, I note how much time in my documentation. And then I go in after and update my registry because then I can count that time. So oftentimes people will ask about how do we measure? The average caseload is about 90 patients, because if I had 90 patients where I was doing all talk treatment, that would not be manageable. But because there's people at all different spectrums, then that's about average. 90% of my time, so 90% of my time should be doing things that I can attach to a patient episode. Calling a patient, talking to a patient, consultation, primary care provider, outreach. Outreach is clearly included in the CMS guidance. So 90% of the things that I do, I should be able to attach to the time for a patient episode. And 90% of my episodes should be billable. And what that means is I've met the minimum amount of time. The minimum amount of time, for the most part, I'm going to exclude the new G code for the moment, is 20 minutes. So that at least billable means that I've hit at least 20 minutes. And that is the 99484 code, which we're going to talk about. A lot of times we'll see people that'll have a lot of episodes, but not have a lot of them be billable because they didn't spend enough time. And so oftentimes that means they're shortchanging themselves and not including things that could be included, or they're not dedicated to this, like our friend Monica, right, who doesn't have the time then to often do the outreach and follow up. And so a lot of times, that's kind of what I was saying, if people are doing multiple things, then you wind up having less episodes that are billable. So you don't always wind up ahead of the game.
You're probably going to talk about tips for totaling up time.
Absolutely, yes. So one of the things, just some common workflows to really help with some of the sustainability. We have found over and over again that entry in an electronic health record should be really one long documentation. So in other words, if I'm in ECW, I open up my tea jelly bean at the beginning of the month. I put in a note and I leave my tea jelly bean open and I keep adding it throughout the month. At the end of the month, I change it to the primary care provider. I close it out. If I'm in Epic, maybe I'm doing a virtual encounter or a non-visit note, even if I have episodes. If I'm in Meden, it doesn't matter, Athena, right, with my cases. And so it's just much easier. So it doesn't clutter up the primary care charts. It allows for billing or audits to be able to see everything in one place. It allows me as the care manager to go back in and add up all the time. It just makes it much easier. There are some registries that will add up the time. There's like Epic where you can put the time functionality in for some places that have pretty high levels of functionality can do it, but for the most part, care managers are adding up the time as they scroll down the one long note. Oftentimes you have to remember if your system has an auto lock, like a lot of times they'll close visits after 3 days if providers don't close them. Many times these types of visits are carved out of that. So it often is really helpful. And at the end of the month, you're adding the CPT code. What I find generally with care managers is that it's helpful to the first month go through, okay, here's the payer, here's the CPT code we would do, here's how many minutes. And then they generally will get it. But that tends to be one of the more common workflows. Otherwise, if I do outreach 5 times, I'm going to have 5 telephone encounters. I talk to the patient 5 times. Now I have 10 telephone encounters, and I would have to open each one of those and count the minutes. Plus, I would have all of those in the chart, which would really be a problem. We talked a little bit about the 99494 code, the 30-minute add-on visit. It cannot be billed independently. There are some organizations who think that this can be billed independently. It cannot. It must be attached to a 99492 or 99493. Some payers are requiring authorization. So there are some payers that after 2, you can, send in an appeal and they will pay them. It certainly is individual, like it's not, it's all over the map. Some of the commercial plans, as an example, will. So Arizona and Mercy Care, is one of them. So they will pay for additional codes. However, oftentimes the codes to me are a red flag. So I had a clinician in my own system. I was looking at lots of 494s and I looked, and she had, 6 or 7 for every patient. She was doing all talk treatment. She was doing lots of different things. And so oftentimes it's a red flag. Generally, when you think about the 2 494s and ongoing care, you want to think about 2 hours a month. You really have 2 hours a month of care, and that includes consultation and registry updating. All totaled, it's about 2 hours. So it's kind of a good number to sort of keep in your head. So when we think about the 99494s, you want to try to remember also that Medicare has what they call the half+1 rule. And the half+1 rule is only for Medicare. And in other words, if I am doing an initial month, a 99492, the half+1 rule means that it's actually 36 minutes I can bill at 36 minutes, because it's half, 35 plus 1, 36. If I'm adding on a 99494, I cannot use the half+1 rule for the first code. I have to use the entire 70 minutes. If I want to use a 494, the half+ code does so that's 16 minutes, right? Because it's 15 minutes plus 1 is 16 for a 30-minute add-on code. So for an initial month, in order to use a 99492 and a 99494, I would have to have at least 86 minutes. For a 99493, I would have to have at least 76 minutes. So it's helpful to remember that half+1 rule. Particularly, it will help you if you don't make all of the minutes. Remember that for your Medicare patients only. So when we think about what some of the denials are, again, it's for more of those 2 494s. Also the dates. So one thing to remember is that because these are monthly codes, you want to reflect the entire month in your billing. And so if I meet the 492 on April 4th and a 494 on April 28th, then what I would do is for the 494 list April 4th, and for the 492 list April 4th, and the 494 list the last day of the month. I will tell some organizations to use the last Sunday of the month as their billing date, because a lot of times in states where there's no same day billing, if I come in to see the primary care provider the last day of the month and I'm a collaborative care patient, it may get kicked back for same day billing just because that's how it works, even though it's not technically same day billing, but because you use the last day of the month on the claim. So the likelihood of that happening is not high, but high enough for us to have to come up with that. So I don't know what else to say. And then I would also say to check benefits. So if I'm using a 99492 and two 99494s, payers will then charge a copay for the 492 and each 494. So you just want to remember to let, yeah, I see Patty's face. Yeah, so to let people know that so they expect it. So granted, it's going to be less likely, but so that you know that people will many times get a copay for each of those codes. So the 99484 code is kind of a fun code. We often say it's the code of last resort. So in other words, if you don't make your time, then you can use this code, which has to be a minimum of 20 minutes. There is no half plus one here. It's 20 minutes or nothing, essentially. It cannot be used by the FQHC providers, right? They get their two codes and that's it. A lot of times there are payers who don't pay this, like Anthem sent something out nationally recently and said, we're not paying this code anywhere at all across the board. There are a few, because this is technically not a collaborative care code, that they send it through their behavioral health carve out for processing. That is particularly annoying because they don't really know what to do with it. And so oftentimes it becomes a bit of a problem. This code, however, can be billed by psychiatry, not just primary care. A lot of folks don't know that. And also recently in many places, clinicians like LCSWs and care managers have been billing this code and getting paid as well. Sometimes organizations will say to me, we don't want to bother with collaborative care, right? We're just going to use this 99484 code. And I would say, you know what, the reimbursement's not really that high to really sort of make it worthwhile. And oftentimes they wind up doing what they would have done in collaborative care anyhow, and could be billing for it. And so I'm not sure I would encourage that line of thinking. So one of the things to kind of keep in mind is that most of the time the collaborative care codes are auto added to contracts. There are very few times, like I ran into something recently in South Carolina where we actually have to add it to the a blue contract, but generally we have not seen that nationally. I would suggest that if you get a denial, don't automatically think it's a real denial. It may be a problem with the claim form. I've known lots of organizations who have given up on collaborative care, and then when they, someone helped them figure it out, it's because the claim forms were wrong. I think it is incredibly difficult to outreach to the payers around this because most of the time they don't know. They hear behavioral health and they send you someplace else. My suggestion is drop the codes. Drop the codes and see what happens. If you get paid, don't poke the sleeping bear. And if you don't get paid, then try to find their guidance and then do a little bit of deep digging around it. But for the most part, you're going to find that they will auto add these to your contracts. And really, we haven't had a ton of problems with the commercial payers. So it's important to think about the copays. You are going to have copays and they're going to be all over the map. Again, specialty providers are going to get specialty copays. If they have a deductible, they're going to apply to these codes. So this January, I saw a huge dip in my census because everybody was waiting to meet their new deductibles, right? And so it was kind of an issue. The copays are really going to vary with plans. Like Humana waived the copay for collaborative care services. So what I would say is that as you do the work, track the specific copays so then you can be more specific with patients. and do it. So I've worked with a lot of organizations. I do this myself, is that I tell patients, listen, you know, don't worry about the copay. I'll take care of it for you. Let's just see what it is. So then, you know, for the first time that I get a particular payer, and then that's going to help sort of inform you. A lot of times people will still ask about the uninsured, particularly the FQHCs. You can certainly, you know, put these codes on a sliding scale, and maybe you do it monthly so that you're sliding the month as opposed to a visit, which is often helpful. And I think the other thing for providers to really understand is that these services often are more affordable than traditional behavioral health services for people, because they're not paying the copays weekly as they see the therapist and then monthly as they see the psychiatrist, that it's equivalent to their primary care copay. So there's a couple of pitfalls that I feel sort of compelled to talk to everyone about. One is the land of Perpetual launch. That is a terrible place. I really don't want to see people go there. Claim forms are incorrect. This happens so many times. I really encourage you to talk to another organization that's getting paid if you're getting denials. And again, no real organizational focus, not sort of dedicated staffing. I've been to many functions and I've talked to CEOs and I said, boy, that was a terrible decision that you guys decided to not do collaborative care. He not only didn't know they decided not to do it, he didn't even know what it was. And so I see that and hear that a lot. So the land of Perpetual launch. This is a never ending, dry and barren, lonely place. And it is where a lot of people get stuck. And the first is that there aren't enough patients. And I would say the warm handoff is nice. I am certainly never going to say that the warm handoff is not a wonderful thing, whether it's done in the office or, you know, someone gives that patient a call. That is wonderful. However, it is actually not enough. I really won't do implementations that are based off provider referral alone, because you just don't get enough patients. Some providers are better than others. They don't really get collaborative care. They're used to just sending people who need counseling or therapy, crying in the office. They often forget patients. They think, oh, I'll just prescribe meds and this person doesn't need anything. And so they don't really sort of get the whole spectrum, and you wind up not having enough patients. And then because you don't have enough patients, then the billing says, well, why am I going to revamp my entire billing and really figure out this complicated billing for 4 patients? And then the administrator says, my billing people are complaining. My behavioral health person is sitting there not doing anything. Why are we doing this collaborative care thing? And then you have some people trying to get it off the ground and get it off the ground, and you know, it just doesn't take off. And so what I really encourage people to do is I set real expectations with staff and leadership. This is what's going to happen. This is what you need to do. And then we're going to do a 30, 60, 90 launch. We're going to be at 30 patients the first month, and we're going to do lots of rapid cycle improvement projects, and we're going to do them every day or every week, depending on how it's going. And we're going to put things in place, like, in other words, if somebody calls the nurse to refill a medication for depression or anxiety, we might say to them, hey, listen, it's really important that we know how well this medication is working. I'm going to transfer you to someone who's going to ask you some questions. And those are the kinds of systemic population approaches that really help make collaborative care successful. When you have a combination of provider referral and 1 or 2 population health approaches, those are the most important and the most successful launches. Particularly now working with an organization in New Mexico, they're putting best practice alerts in their system so that there's reminders for providers. It's really important. And then so 30 patients the first month, 60 patients the second month, 90 patients the third month, and we get everybody on board and we continue doing it till we figure out what's working. And then at the first month, the billing says, oh, wow, we have 30 claims. We have to figure this out. We're going to get a broad spectrum of payers. We're really going to figure out what's working. And it seems to be much better. So sort of in conclusion, who's really going to struggle? And I will say I almost always can get practices to be self-sustaining. Like once you have the volume and you put some systems in place, then you will likely be wonderful at doing collaborative care. I worked with an organization recently in Texas. The woman said to me, 60% of our patients are uninsured. I said, yeah, you're not going to be self-sustaining, like, but you're used to that because nothing you do is self-sustaining. So, but certainly they're doing it and they're going to do a great job. Small practices that have big commercial pay, like lots of commercial payers, and they're small, they can't really negotiate better rates, and they have a lot of commercial plans that don't pay well. So I had a small practice in New York. They really wanted to do collaborative care. They had a whole bunch of patients from these commercial plans that just paid terrible. And it was very hard to sort of get it up and running. I mean, terrible, like $30, terrible. And so also I would encourage you to think about the depression screening and using some of the codes to really optimize, and some of the new, like the 96130 on the primary care side, to be able to do some optimization. So we have a couple minutes for questions, and hopefully we got to answer some as well.
One question that came out was, do most practices have a specific CoCM biller, or do the care managers do their own billing or some other option?
So the care managers should not do the billing. What they should and generally do is the coding, because they're the ones that know the minutes and know that, and they can just scroll through and they can code the encounter. So they can put in a 99492 or 99494, and they generally close the encounter and route it to the primary care provider, or change the authorizing provider and close it out. Most places don't have the volume to have a separate CoCM biller, but they usually have someone on the team that has the hang of it and does it. Once organizations get the hang of it, then it actually goes out pretty quickly, especially if they've done chronic care management or health home or some other kind of monthly billing. Once they get it, they're good to roll.
How hard is it, how important is it to have the behavioral health manager on site? Some of the practices still insist that they want the person around to be able to talk to them. But how does this affect the efficiency?
So you could do it either way. I think oftentimes a combination of both. You have somebody on site, 1 or 2 days a week maybe, and then telephonic. But I mean, my whole organization is based on the premise of just doing telephonic or video. And certainly, I think it's better when providers really understand what collaborative care is. And I also hear a lot from providers. My patients want in-person therapy, and the patients say, can you just call me on the phone? So there's oftentimes a discrepancy in terms of, what's really helpful for patients as well. But it can happen either way. And there are some really busy practices where it's helpful to have somebody there, or depending on the population, homeless site or something maybe.
And I know we're at one. I have one more question. Do you keep track of clinical outcomes at 6 months by the program? Because there's been a recent article talk about how it's hard to reach a response in 6 months because of problems with implementation.
I would say if you fix the problems with implementation, then no. I use 50% or 10 points at 90 days, and more than 60% of our patients reach that goal in my own organization, which has a census of about 4,000 collaborative care patients. So I have always stuck to that benchmark. I've never changed it to 5 points or to 6 months. And I always move organizations to that. If you do your implementation right and you get the patients and you train your care managers around how to really bring the PHQ and the GAD into the session and be symptom focused. The other piece is many times I go into organizations and the primary care providers have no idea that there's outcomes. that nobody ever shared with them that there was a 50% or 10-point reduction and it was a benchmark. So to make sure everybody's aligned.
Yeah. And I know we're out of time, and are you okay with sharing the PowerPoint slides?
Oh yeah, totally.
So on, I'll send out an email, but they'll also be on our CFHA Psychiatry SIG website. So we'll have the PowerPoint there and the recording there. And thanks everyone for being part of this. And you'll see Virna has posted her email address, virna@concerthealth.io. So thanks everybody. We're getting some comments, Virna, that this has been a great presentation and very informative. I really appreciate your time.
Thank you so much, everyone. Have a wonderful day.
Take care.
Bye-bye.